right, good morning. This is the auditory learner. This is going to be the final review for pharmacology. Um, and we're going to start in with the week 5 final check-in quiz. Let's start with the drug names again. So we're going to say that metformin is a biguanide, insulin aspart is a rapid-acting insulin, glimepiride is a sulfonylurease, Ozempic is a GPP1 receptor agonist. Pramlintide or Simlin is an amniolimnolimimetic agent. Prednisone is an oral adrenocorticosteroid. Triamcinolone acetonide is a topical adrenocorticosteroid. Methimazole are drug treatments for hyperthyroidism. Methimazole. Synthroid is drug treatment for hypothyroidism, and Sprintec is a contraceptive. All right. Also, destruction of beta cells is classified as type 1 diabetes. Oral absorption of insulin is high. That's going to be false. Oral absorption of insulin is not high. It's almost zero bioavailability. Insulin is used in both type 1 and 2 diabetes. Which of the following is a common adverse reaction to insulin? That's going to be injection site reactions. The hormone that counteracts insulin is called glucagon. Sulfonylurases, they work by depolarizing beta cells. DPP4 inhibitors and GLP-1 receptor agonists have closely related mechanism of actions. That's true. SGLT1 inhibitors cause the release of glucose and what ion? That's going to be sodium. Which of the following is an adverse reaction of metformin? It's going to be increased lactic acid production. Which of these is a common adverse reaction to adrenocorticosteroids? That's going to be weight gain. All right, which of the following would you expect in a person who has adrenal insufficiency? That's going to be fatigue. Which of the following is not a common treatment for hyperthyroidism? It's going to be exercise and diet. That is not a common treatment for hyperthyroidism. Overdose of thyroid hormones could likely cause tachycardia. Which of the following could be used for treatment for low testosterone in male? That's going to be clomiphene. And then here's another one. Choose all that apply. Contraceptives usually contain 2 drugs. That's going to be progestin and estrogen. Which of the following is a symptom of hypogonadism in male and females? That's osteoporosis. Which of the following is used for breast cancer? And that is the drug anastrozole. All right, so now that we got that out the way, we're just going to do a quick recap of everything that's going to be on this final. Okay, let's start. So we're going to go all the way to the cardiovascular, I believe. That's the cardiovascular system. Let's see what we're at here. All right. So we're going to start with seizures. All right. So we know that the condition of people who have seizures is called epilepsy, right? Seizures are misfiring of neurons. There's different types of seizures. There's generalized, there is partial, and then there is miscellaneous. For generalized, there's absence seizures and tonic seizures. Absence seizures are loss of consciousness, but people still appear fine and they maintain muscle tone. Tonic-clonic seizures are also loss of consciousness with major muscle contractions, facial jerking, and stiff limbs. The first choice drug for absence seizures are ethosuximide. The first choice drugs for tonic-clonic seizures are lamotrigine. Then we have the partial seizures. These are simple and complex. The simple is no loss of consciousness. with a small region of the brain affected. So these people are conscious. Um, and a small part of the brain. First choice drug for that is carbamazepines. And then the next one is complex. This one is a loss of consciousness with the small part of the brain affected. Um, the first choice drug for this one is lamotrigine. The similarities here are between tonic-clonic and complex, except for tonic-clonic, there's loss of consciousness, and complex, there is not. For tonic-clonic, I take that back. Tonic-clonic and complex both have loss of consciousness. The only type of seizure that does not have a loss of consciousness is the partial simple. Okay. And then we have status epilepticus, which is a tonic-clonic seizure that lasts more than 5 minutes. The first choice drug for that is going to be IV diazepam. Okay. There are various adverse reactions to anticonvulsants. Okay. They all have CNS depression, GI issues, liver enzymes, birth defects, and withdrawal symptoms. Okay, so we'll start with valproates. Those are the oldest drugs for epilepsy. All right, mechanism of action is unknown, bad for the liver, hepatotoxic, causes extreme exudation, and there's valproate acid, valproate sodium, divalproate. There's also lamotrigine or lamictal. That's a sodium channel blocker like lidocaine, given in pill form. It's better for older people and for bipolar disorder as well as depression. It does not affect liver, but if combined with valproates, it will increase. May cause Stevens-Johnson syndrome, which is sloughing of the skin. Then we have levetiracetam, Keppra, inhibits neurotransmitters metabolized by the liver. It's not interacting with the drugs, safer in that respect. Still can cause Stevens-Johnson syndrome. There's carbamazepine, sodium channel blocker like lamotrigine. Carbamazepine is the one that treats trigeminal neuralgia. It also seems to me like carbamazepine is one of the ones that has the most adverse reactions. There's anemia, agranulocytosis, thrombocytopenia, alopecia, induction of liver enzyme, decreases the effectiveness of doxycycline, theophylline, and contraceptive, and causes xerostomia. Then there's oxcarbazepine, similar to carbamazepine, but safer with less induction of liver enzymes. Then there's phenytoin. This was popular, but not anymore due to heavy adverse reactions, heavy reactions. This one, phenytoin, vitamin D, B9 deficiency, very strong embryonic and fetal teratogen, does cause Stevens-Johnson syndrome and hirsutism, gingival enlargement. And then there's cannabidiol or Epidiolex. All right, cool. As we know, Italy has done the most for that one. It's not a psychedelic, and you don't need a prescription for that. Let's go into bacteria now. We have gram-positive, gram-negative bacteria. We have the shapes of bacteria where we have the spheres are cocci, rods are bacilli, squiggles are spirochetes. Gram-negative stains pink, gram-positive stains purple. Okay, gram-negative has the lipid lipopolysaccharide layer, which is the LPS layer, and gram-positive does not. Gram-negative stains pink due to thin cell walls. Gram-positive stains purple due to thicker cell walls. All right. Antimicrobial drugs. Okay, here we go with these. Penicillins. They're part of the mold family with the B-lactam ring, discovered by Alexander Fleming in 1928, given orally and parenterally, but never topically due to allergic, does cross the placenta, breast milk, and distributed to all tissues except for CSF, bones, and abscesses, still high in therapeutic index. Penicillin G is given orally, but it's 15 to 30% bioavailable. And there's IV potassium and IM benzothine. IV potassium is quick, IM benzothine is slow. But we should not be giving IM benzothine or sodium salts to cardiac patients. Penicillin B has a higher bioavailability. It's acid stable, 30-minute half-life. So short, multiple doses are needed. Pen B, free base, Pen BK, potassium salt route is best. Amoxicillin is used for prophylaxis for dental procedures, for upper respiratory infections and urinary tract infections, taken 3 times a day rather than 4 times a day, metabolized by the liver by hydrolysis, not by P450, and eliminated through the urinary system and convoluted tubules. That's amoxicillin. It also kills bacteria um, by bonding to the transpeptidase, which can lyse bacteria. Can kill some gram-negative like gonorrhea. Resistance is caused by bacteria with the lactamase enzyme, known as pelicinellase. Nosocomial infections are dangerous. 95% of them are hospital staff species. 5 to 10% of patients are allergic and get worse in continued use. Rashes, hives are 80 to 90% allergic reactions. 0.05% of patients, 1 in 5,000, will have anaphylactic shock with amoxicillin. Then we have cephalosporins. These are related to penicillin, but they have B-lactam ring, but it is resistant to B-lactamase. So basically, if you have bacteria that are resistant to penicillinase or penicillin, you can get cephalosporin, especially because they are resistant to B-lactamase, but still have the same mechanism and actions as penicillins. Bacteria can be resistant to this as well with cephalosporinase. This is the more expensive though. Mostly gram-positive, 5 generations with a wide spectrum. Adverse reactions similar to penicillin, which can lead to hemolysis and anemia. All right, then we have the macrolides. Macrolides, these are azithromycin, erythromycin, clarithromycin. Similar to penicillin, but used for infections like whooping cough. First choice for patients with penicillin allergy. Okay, metabolized by CYP450 and inhibits liver metabolism, which can increase effect of warfarin, triazolam, digoxin, and carbamazepine. Adverse reaction is cholestatic jaundice, which stops the flow of bile and causes vomiting and nausea. Let's talk about now tetracyclines. Tetracyclines are tetracycline, doxycycline, and minocycline. That's the family of antibiotics. They inhibit ribosome translation. There's antibiotic resistance is common, especially with S. viridans, S. aureus, taken orally, distributed to all tissues, including saliva, placenta crossing abilities, to source of teratogen, milk, enamel, dentin, and gingival crictal fluid. Used in periodontal disease when unresponsive to treatment. So can cause affects fetal development, especially in the second half of pregnancy, causes yellow teeth. And that's irreversible, bad for the liver, horrible for human kidneys, especially when it's expired. Nephrotoxicity. Best be taken outside of mealtime, should be taken with dairy products, antacids. Doxycycline elimination is mainly through feces and renal. Minocycline is the next one that can cause blackened or blue hue behind the mucosa. That is reversible. These tetracyclines have enterohepatic circulation, which means that it's eliminated in the bile and reabsorbed in the small intestine, and it's a cycle that makes drugs hang out longer in the system. Next, we have clindamycin or cleocin. It's not bactericidal, it's bacteriostatic. Okay, food does not interfere with absorption, metabolized by liver, eliminated through feces. Then we have a nosocomial infection like pseudomembranous colitis, which is caused by Clostridium difficile. It's blood and stool. Okay, and then we have metronidazole. Well, pseudomembranous colitis, the major issue is with clindamycin. Okay, so that's why you got to complete the regimen. Then we have metronidazole, which is Flagyl. It is bactericidal, trichomonocidal, and amoebicidal. Treats STDs and amoeba intestinal infections used in dentistry for periodontal disease or anaerobic bacteria, taken from alcoholic liver disease and contraindication. Great. So penicillins, Pen B, Pen C, amoxicillin, ampicillin, cephalosporins are cephalexin, Keflex, or cefazolin. Second generations of that was the first generation. Second generation is cefaclor. Third generation cefixime. Fourth generation cefepime. Fifth generation are ceftobiprole. Macrolides, we know are the mycins. Tetracyclines are the cyclins, and the other ones are clindamycin and metronidazole. These are one-member families. All right, we talked about protists and fungi. All right, we know that protists and fungi are both eukaryotes, with the exception that protists are well, they have a nucleus and membrane-bound organelles. They can be multicellular. Fungi, they have cell walls made of chitin. They mostly are multicellular, but they don't require light because they don't need to photosynthesize. They reproduce in spores. Oral fungus in dentistry is called by Candida albicans, which can cause thrush. These are for immunocompromised diabetic or prednisone inhaled corticosteroids. Now let's talk about viruses. These are the robot hackers. They're and are 100 times smaller than bacteria, and human cells are 1,000 times bigger. Viruses have no organelles, no ATP. They have capsid. They contain genetic nucleic acids. It's single or double-stranded. Capabilities of being an obligate intercellular parasite. That's what they're called, robot hackers. All right. So then we have the drugs to treat fungus. Okay. So we have nystatin, binds to sterols in the fungal membrane, which increases permeability. Pharmacokinetics for nystatin is not absorbed by mouth, poor absorption in small intestine, minimal distribution. It's an oral lozenge, which is the most effective, or oral suspension to be absorbed. All right, then we have imidazoles. Imidazoles are similar to metronidazole with 5-part ring, like clotrimazole, Lotrimin, topical that binds to phospholipids. Same pharmacokinetics as nystatin, but binds to oral mucosa intestine. Then we have miconazole, which is monostat over the counter used for yeast infections. So we're talking about fungal drugs here. Vaginal, jock itch, other skin, and then we can be compounded if absorbed interferes with cytokine. Then we have ketoconazole, which is another antifungal shampoo over the counter, similar membrane permeability. This can be absorbed by small intestines, goes everywhere except partitions and bone, metabolized by liver, eliminated through feces. Then we have fluconazole, destabilizes the same cell membrane, used more for serious blood-borne fungal infections. Adverse reactions, same as ketoconazole, which are GI upset, teratogenicity, hepatotoxic, and high absorption, which interferes with CYP450. Now we're going into the antivirals. So not really used in dentistry except for but treatment for common colds and HIV, hepatitis, COVID-19. All right. HIV is a retrovirus. It does reverse transcriptase. Herpes simplex 1 is sores on the lips. Herpes simplex 2 is a genitalia. So acyclovir Zorovax treats herpes simplex is double-stranded DNA, stops replication of viruses. It lacks deoxyribose 3' hydroxyl, just prevents outbreaks when it's active. Then we have daconazole, Abreva, treats herpes simplex as well, similar to fatty acid chains. Prevents from fusing to host cell, used topically, which decreases healing time by about half a day within the first 12 hours. Then we have oseltamivir phosphate Tamiflu, treats influenza, decreases duration by flu by about 3 to 4 days when given within 48 hours of first symptoms. Prevents activity of neuraminidase, stops shedding, prevents infection. Then we have nirmatrelvir. This one treats COVID-19, protease inhibitor, prevents cold COVID maturation. When exocytosed, it has no effect on the body. Then we have ritonavir, Paxlovid, treats COVID-19 as well, emergency use medication. However, it is also an HIV drug to inhibit CYP450, increases half-life of nirmatrelvir, which is why it's used together. Then we have zidovudine, AZT. This is the first treatment for HIV in 1987, which was only slowed it down. It is a nucleotide reverse transcriptase inhibitor, NRTI, which prevents elongation, but resistance is common. And Caltera and Biktarvy are both polytherapies used for HIV, which combination of two protease inhibitors, and also an NRTI. Polytherapy, and we know what that is because resistance to antiviral is evolutionary costly. We know what PrEP and PEP is. PrEP is pre-exposure prophylaxis given to populations with high risk of HIVs. Prevent 99% of sex-related HIV. Drugs are Truvada or Descovy. Bad side is that it can cause severe renal issues and resistance. That's why these people need to have constant blood tests. And then PEP is post-exposure prophylaxis. That happens when a patient or you poke yourself with a needle or somebody spits blood at you or your face. If that is a medical emergency, it must be taken within 72 hours to be taken for 28 days. Truvada is taken twice a day, while Tegavir is taken twice a day, or Tegavir once a day. Great. Week 4, that was week 3, week 4. This is cardiovascular, digestive, urinary. Again, I'm going to go through this pretty quick. Okay, so the function of the heart is to pump blood. Okay, there's 4 chambers with atriums and ventricles. The base of the heart is the superior border with the aorta, superior vena cava, and the pulmonary artery. Fossa ovalis is the right atrium, ligamentum atriosum. They're both from fetal development. Okay, we have the pericardium, epicardium, which is the sac that's continuous with the diaphragm, contains the heart. You have the mesothelium, which is the visceral layer. Arteries bring blood away from the heart, and veins bring blood back to the heart. Arteries, veins, and capillaries are for gas nutrients exchange. Okay, arteries have more elastic fibers for pressure and are thicker. Veins have valves due to low pressure and gravity. Arteries do not have valves. Most of the blood is in the veins. The medium cubital vein is used for blood draws. The myocardium is the cardiac muscle with cardiomyocytes, non-voluntary. The endocardium is the most endothelial tissue. Tricuspid valve is on the right. The bicuspid valve is on the left side of the heart, and it's the weakest valve. Now, the urinary system, it's kidney, renal, all means the same thing, excretes, filters waste. Functional units of the kidneys are nephrons. Blood goes from entering into arterial to glomerulus in Bowman's capsule. And then it filtrates, glucose, sodium, and amino acids extracted from bloods. Most of the length of the nephron is in loop of Henle, which is the medulla. Okay. We have antihypertensive, which are thiazides, chlorothiazide, hydrochlorothiazide, loop diuretics, which are bumetidine, ethacrinin, furosemide, torsemide. We have carbonic anhydrase inhibitors, which is acetazolamide, methazolamide, dorzolamide. Potassium-sparing diuretics are spironolactone, tram, ACE inhibitors are prils, ketropril, enalapril, lisinopril. ARBs are sartan, losartan, or melsartan, valsartan. Vasodilators, alpha-1 blockers are Zosyn. Doxazosine, prazosin, terzosine. Calcium channel blockers are nifedipine. PDE5 inhibitors are the penis drugs, Afil, sildenafil, and tadalafil. Alpha-2 agonists are clonidine, methyl-dopa. Beta blockers are pronolol, metoprolol, propranolol. Drug treatments for heart failure are digoxin, ivabradine. Anti-anginal drugs are nitroglycerin and ranolazine. Antiarrhythmics, we have class A, 1A, 1B, 1C, 1 and 2, 3, and 4. Hyperlipidemic drugs are statins. And anticoagulants are aspirins, Coumadin, and heparin. Let's see, antihypertensives are diuretics. There's 3 mechanisms. They dilate the blood vessels, decrease blood volume, decrease contractility of the heart. So we need to understand the renal angiotensin system. So that means aldosterone circulates through the blood released by adrenal glands, which causes retention of water and sodium absorption, and water follows. Then there's an anti-diuretic hormone or vasopressin. It's faster than aldosterone, increases water absorption. The renin-angiotensin system activates aldosterone and antidiuretic hormone and directly influence the nephron absorption. Very complicated. Incorporate the liver, kidneys, and cardiovascular system. But this is how ACE inhibitors works. ACE inhibitors stand for angiotensin converting enzyme. The COVID virus binds to ACE, to angiotensin converting enzyme. Long-term effects of COVID affect cardiovascular systems such as endothelium and heart, such as myocarditis. All right, so we know that heart disease, coronary artery disease is buildup of plaque. And high blood pressure can cause rupture of plaque, which leads to myocardial infarction. usually at the left anterior descending artery, which is the highest pressure, one of the highest pressure arteries, and can cause ischemia, lack of oxygen, which can lead to ventricular fibrillation. There's bypass surgery. There's cardiomyopathy, with the heart working harder than needed. Then there's hypertension is the most common cardiovascular disease. 45% of the population affects men more. Constriction of arterioles can cause stroke, kidney, and retina damage. Treatment is exercise, weight loss, low sodium diet. Classify major cardiovascular drugs. Cardiovascular disease is the #1 killer in the US. It includes hypertension, high cholesterol, and heart attack. Monotherapy, polytherapy. Monotherapy is used only for stage 1 hypertension. Take a single drug, depends on the race, and is kind of contentious. Non-blacks take thiazides, ACE inhibitors, ARBs, and calcium channel blockers. Blacks only thiazides and calcium channel blockers. Polytherapy used for stage 2 or stage 3 hypertension. 2 or more drugs. Usually 70% of patients require more than 1 drug. Diuretics, increased urination, are ACE inhibitors. ACE blockers or calcium channel blockers are the 4 most used drugs for hypertension. All right. Think about thiazide diuretics. Chlorothiazide, they prevent sodium reabsorption. Adverse reactions for thiazides, hypokalemia, low potassium, can lead to arrhythmia. That's the major issue. Xerostomia, drug NSAIDs decrease antihypertensive effects. So it's not toxic, it's just that it decreases the effects. Then there's loop diuretics. Same mechanism as thiazides, adverse reactions are more severe. They block the sodium potassium pump, which increases volume of filtrate. Lupifamine, not the first choice. Carbonic anhydrase inhibitors are acetazolamide, methazolamide. Sodium absorption, slow sodium absorption, not used as often. But there's a bitter taste. Sulfonamide structure can cause allergic reactions. Potassium-sparing drugs, these are weak and cause more severe potassium, but conserve more potassium. Spironolactone is a potassium-sparing diuretic similar to aldosterone. A triamterene antagonizes sodium-potassium exchange, increases filtrate. There's a ACE inhibitors prevent formation of angiotensin II. No more formation of aldosterone and causes vasodilation, and it's a diuretic. So lisinopril and allopril, capetopril, they're stronger than diuretics, which can cause hypotension, fainting, nausea, fatigue. Think about ACE inhibitors, they can cause hyperkalemia. So if you remember, the thiazides can cause hypokalemia, but ACE inhibitors can cause hyperkalemia. Okay, so hyperpotassium, too much potassium. And may be used with loop diuretics to balance out. Contraindications are teratogenicity, pancreas issues, taste perception, xerostomia. ARBs, angiotensin receptor blockers, are losartan. This is an angiotensin II receptor antagonist. Similar adverse reactions come to endogenous ACE, just slightly different mechanism. Vasodilators are ACE and ARBs. They can't fit into here, but they're usually, but these drugs are going to be causing only vasodilation. So alpha-1 blockers, they block the adrenergic receptor to decrease smooth muscle contraction. Use, like other drugs like beta blockers, is direct. Samples of these are doxycycline. Adverse reactions are incontinence. Epinephrine should be avoided for alpha-1 blockers. Calcium channel blockers are also vasodilators. Similar to alpha-1 blockers, but cause vasodilation and prevent calcium channels from opening, like nifedipine, GI upset, xerostomia, gingival enlargement. PDE5 inhibitors are also vasodilators. These are sildenafil, allophil, cause GI upset, priapism, increases effect of nitric oxide. Alpha-2 agonists decrease sympathetic activation, so dilation of blood vessels and cardiac output, cause xerostomia. Beta blockers, propylol, metoprolol. These decrease cardiac output, and adverse reactions are decreased athletic ability, GI upset, hypotension, enhanced effect of epinephrine. ACE inhibitors are not safe during pregnancy. Co-administration of epinephrine to a patient on alpha-1 blockers would cause vasodilation. Administration of epinephrine to a patient on beta blockers would cause enhanced vasoconstriction. All right. So we're going to talk about hypertension. Causes the heart to grow in size, causes hypertrophy of the heart, can lead to heart failure, thinning of the myocardium. All right. Inability to contract. This is a giant left ventricle. Stage D is where it fails. Digoxin, used to treat heart failure. Digitalis glycosides, very low therapeutic index, not 100%. It's 1 to 2. Can be very toxic. Inhibits sodium potassium pump. Adverse reactions are arrhythmias. Tetracycline and erythromycin can increase digoxin levels. Then we have ivabradine, which is just a funny channel blocker. Then we have nitroglycerin, used for angina pectoris, pain in the chest, upper limb caused by clogged arteries. Given sublingual tablets, nitric oxide released to release smooth muscle coronary arteries. If patients are taking penis drugs, can cause extreme hypotension. Also, can have patients can have tolerance. It is explosive. Ranolazine is the final option if nitroglycerin don't work. Increases QT interval. All right. Then we have antiarrhythmic drugs, but the only ones we need to know are 1A, 1C, and class 3. 1A is quinidine, 1C is flecainide, and class 3 is botulinum amiodarone. Okay, statins, alter cholesterol levels, and fish oil and all that stuff. Let's talk about statins really quick. Almost done. All right. So statins or HMG CoA reductase inhibitors for hyperlipidemia. Most lower VLDL, LDL, triglyceride, and total cholesterol, but they all raise HDL. GA upset, hepatotoxicity, tiredness, fatigue. Fish oil can be used. Then we have coumadin and warfarin, which is an anticoagulant. All right, and heparin. Heparin is an IV anticoagulant used during a myocardial infarction. Takes very fast effect. Okay. I wonder how much of this is going to be a fucking test. Anyways, all right. So just went over all that stuff. Now we're going to talk about the digestive system. Starts in the mouth. Peristalsis keeps things moving. Small intestines have villi, increased surface area. There's GERD, ulcers, peptic ulcers, which can be caused by NSAIDs. Tums is an antacid. Omeprazole is proton pump inhibitor. Scopolamine is an antiemetic. Fleet is a laxative. So acid reducers are H2s, receptor blockers, Tagamet, famotidine, Pepsid, or the counter. Headache and QT elongation. Then there's proton pump inhibitors, which is omeprazole, esomeprazole, Nexium. GI upset, okay, acid neutralizers, antacids, Tums, Rolate, bismuth, salicylates, Pepto-Bismol. GI issues, has oligodynamic effect, metal-like, can kill some pathogens. Antacid as well as reduces motility of stomach. Then we have laxatives. There are different types. There's bulk lubricant, stool softeners, right? There's osmotic saline, U receptor, and yeah, so Metamucil is a bulk laxative. It is cellulose and fibers absorb water, adds feces. Mineral oil is a lubricant type, not absorbed but speeds excretion. Bisacodyl Dulcolax is a stimulant type laxative taken PO suppository. Irritate intestines and increase contractions. There's docusate sodium is a stool softener type. Similar to bulk but weaker and attracts water feces. Magnesium sulfate fleet is osmotic saline type, given as an enema and wet feces. There's a mu receptor antagonist, causes constipation, like naloxone. And then that's a prescription you needed for that. And then chloride channel activators increases intestinal excretions. Antidiarrheals, it's like Pepto-Bismol, inhibit intestinal secretions, slows it down intestinal, but no CNS defects. Antiemetics means preventing from vomiting. Okay, CNS antihistamines is the major mechanism. First generation antipsychotics like chromoprazine are antiemetics. Anticholinergics such as scopolamine can be used as an antiemetic, and first generation antihistamines such as Benadryl can be used as an antiemetic. Over-the-counter laxatives do not have systemic effects. All right, know that. Talk about the respiratory system now. Site for gas exchange, immune response, medulla and pons control the diaphragm. We know the upper respiratory system is a nasal cavity. The pharynx warms, cleans air, alters voice and smell. The nostrils are elastic with hair to touch. The nasal conchae are part of the ethmoid and maxilla. Pharynx has nasopharynx, oropharynx, and lower respiratory system, larynx and trachea, hyoid, bone, epiglottis. Trachea leads to the lungs. Trachea has a mucociliary escalator, very important for part of the immune system to bring things out. Carina is the split where the trachea and the main bronchi split into right and left of the lungs. Asthma occurs at the bronchioles. Trachea has no smooth muscle. Cartilages are thyroid, cricoid, tracheal, arytenoid, corniculate, cuneiform. Corniculate and cuneiform are part of the vocal cords. The lungs have a pleural cavity with 5 lobes, very vascular, driven by diaphragm. 3 lobes on the right and 2 lobes on the left. Cardiac notch is on the left lung. Both have apex and base. The bronchioles are right before the alveoli. Alveoli is where gas is exchanged with surfactant and macrophages present. It's very vascular. Hiccups are spasm of the phrenic nerve C3 to C5. No treatment, but antipsychotics can be used. Respiratory drugs. All right. Benadryl is first generation antihistamine. Claritin, second generation. Albuterol is a beta-2 agonist, and prednisone is a corticosteroid. Treatment for asthma and COPD. Asthma is inflammation of bronchitis and increased secretions. Shortness of breath, wheezing, hypoxia, and an attack is a sudden onset of those symptoms. COPD is chronic bronchitis, and emphysema is destruction of the alveoli and airway collapse, more serious in asthma. All right, so we have allergic rhinitis, hay fever, runny nose, sneezing, itching, and red eyes. This is not asthma. For that, you need antihistamines, which are H1 blockers. First generation, Benadryl, Unisom, promethazine, hydroxyzine. Second generation, do not cross the blood-brain barrier, minimal sedation. All right. Yeah, so there's all this stuff. I'm not going to go over week 5 diabetes because we just did that, but I'm going to end it here with chapter 17 with the antihistamines and COPD. Feel that feels right. So again, just know corticosteroids inhibit the immune system by stopping itching, such as hydrocortisone. Beta-2 agonists or sympathetic agonists cause bronchodilation. This is albuterol. It's inhaled and absorbed by the blood. Half-life 4 to 6 hours. Causes tremors and dry mouth and anxiety. Short-acting used more frequently. Long-acting are used for severe forms like COPD. Anticholinergics are used mainly for COPD, which causes smooth muscle relaxation and bronchodilation. It's inhaled as well as and causes xerostomia. So that being said, I'm just going to kind of review the drugs for COPD and stuff like that. Which should be here somewhere. Yeah. Again, beta-2 agonist, albuterol, metoprolol, levobutyl, some anticholinergic, COPD, aclinidium, and rivefenacin. Then there's corticosteroid, prednisolone, and fluticasone. Antihistamines first generation are Benadryl, doxylamine, Unison, promethazine, hydroxyzine. Second generation are cetrizine, Zyrtec, Claritine, loratadine, and fexofenadine, Allegra. Dope. And that's where we're going to end it for the final review.